Wow, qué interesante. Muchísimas gracias, doctor Luca. Estamos muy agradecidos por su conferencia extraordinaria. A continuación, en estos pacientes que nosotros le practicamos laringectomía, usualmente uno de los grandes problemas que tenemos es precisamente la emisión de la voz. Tenemos al doctor Rudolf Hagen, que nos visita desde Alemania. El doctor Rudolf es director de la Clínica de Cabeza y Cuello de su institución desde el año 2005. Tiene tesis doctorales en farmacología. Organizó en Stuttgart la Escuela Moderna Europea desde el 2004. Su línea de investigación se basa precisamente en la reconstrucción laringea, precisamente con tejidos autólogos, para poder aquel paciente que ha sido sometido a la laringectomía pueda tener fonación. Él nos visita desde Wurzburgo, Alemania, y va a hablar precisamente sobre la laringoplastia microvascular. Bienvenido, Dr. Rulfo. Welcome, Dr. Rulf. Go ahead.
Dear colleagues, welcome to the lecture on microvascular laryngoplasty. My name is Rudolf Hagen. I'm the chairman of the Department of Otorhinolaryngology, Plastic, Aesthetic and Reconstructive Head and Neck Surgery of the University of Würzburg in Germany. This is the head clinic of Würzburg, which was constructed in 1970. Würzburg is an ancient German university town and located in the southern part of Germany at the River Main, just 120 kilometers to the east from Frankfurt, in the north of Bavaria. In cases of extended the laryngeal skeleton destroying tumors, total laryngectomy remains the only surgical option for a safe, complete tumor resection and a reliable sanation of the advanced cancer. Nevertheless, many patients prefer an organ preservation concept in order to avoid the necessary permanent tracheostoma. Of course, oncological results are in favor of the surgical solution. This simple knowledge is repeatedly confirmed in literature. Here one recent paper from last year. Here another paper published in Head and Neck, analyzing the data of nearly 7,000 patients. Removal of the larynx implicates a separation of the airway and the pharynx, creating a permanent tracheostoma and a missing sound generator. The possibility to create some sound by vibrations of mucosal folds within the pharynx is called esophageal voice. Patient is independent from any apparatus or special cannulas. There is no need for further interventions, and aspiration is excluded. However, this is no immediate voice restoration. Long-lasting training is necessary. Pharyngeal voice has a low frequency, which is a problem for female patients. There is a strictly limited period of sound production, as the air for speaking has to be swallowed before. There is a reduced sound volume. Patients often suffer from voice fatigue and therefore rarely develop a socially well-usable voice. The pharyngeal voice can be operated much better if the air reservoir of the lungs can be used. Therefore, Very early surgical techniques have been developed in order to establish a permanent connection between trachea and the pharynx or the upper esophagus, called voice shunt. Asai from Japan used inverted skin of the neck. John Conley, esophageal mucosa, and the Austrian Ehrenberger, a so-called speech siphon using a jejunal segment. Here, the modification by Stefan Remmert, who suspended the upper part of the siphon by use of a digastric muscle sling. Main problems of these techniques have been an intolerable aspiration or an unintended closure, especially following postoperative irradiation. The idea of the Polish surgeon Mosulewski in 1972 to perform a simple puncture between the trachea and the upper esophagus and to insert a small valve had its breakthrough some years later when it became possible to produce these valves in an industrial way. Now, these small valves were named voice prostheses, although they actually do not produce any sound. In the beginning, these valves were changeable by the patient himself if he acquired the necessary skills. Here a patient inserting his voice prosthesis by himself in front of a mirror. These self-changeable systems were left in favor of permanent valves, here for example the Provox prosthesis. There are clear advantages in the use of voice prosthesis. It is a simple surgical procedure. You can start with the voice training quite early. One has a normal period of sound production with a constant frequency, which is similar to esophageal voice. And normally you obtain a sufficient volume. On the other hand, there are some disadvantages of these valves. You have to close the stoma to direct the air into the pharynx, which guides the lux to the permanent stigma. Some patients have a very high phonation pressure. In some cases, the foreign body causes extensive formation of granulation tissue, which has to be removed regularly. The valve gets insufficient after a while and has to be changed regularly. If the shunt gets too wide after irradiation, severe problems with recurrent aspiration can occur. Fundamental frequency is too low for female patients. Sometimes the change of the prosthesis is difficult, for example if the shunt is wandering downwards. And of course, these valves are expensive, what can be a problem in some countries. If one inserts a voice prosthesis primarily, it is recommendable to perform myotomy of the constrictor pharyngeus muscle. Here, this is carried out in the posterior median line. A suture to the prevertebral fascia on both sides prevents a closure of this gap. Microvascular reconstructions following extended resections in the head and neck area improved functional results dramatically. We started in the 80s of the last century using free jejunal grafts. Here a pharyngeal reconstruction following total laryngopharyngectomy with a microvascularly anastomosed jejunal segment. Due to the complex handling of this transplant, we switched to the free forearm flap, which became the workhorse in our reconstructive setting. In 1989, we performed for the first time a forearm flap reconstruction for voice restoration following total laryngectomy. The flap is sutured like a tube and inserted between the tracheal stump and the base of the tongue. Here, tracheal stump, base of the tongue. A neoepiglottis, which is reinforced by a piece of cartilage and the suspension of the tube at the hyoid bone or the digastric muscles prevent aspiration. Here the outline of the incision on the forearm. The broader distal part is for the laryngeal substitute tube. The smaller proximal part here for the neoepiglottis. Broader distal part for the laryngeal substitute tube and the smaller proximal part. The laryngoplasty is created in the forearm. The neoepiglottis is reinforced with a piece of cartilage. Here the laryngoplasty inserted in the neck between the tracheal stump down here and the base of the tongue here. In this case, the hyoid bone was used for suspension.
Essen und Trinken geht wunderbar.
Ja, prima, keine Beschwerden.
Sie haben wieder Gewicht zugenommen.
Ja.
Ja, weil es gut schmeckt.
Ja.
Und wie ist es mit der Stimme? Kommen Sie damit klar?
Ja, und was ich, ja, ganz gut.
Mhm. Und die Handhabung, das Handhaben von dem Ventil?
Kann die gut.
Das geht?
Ja.
Macht keine Probleme?
Nein, ich kann sie rausmachen, kann sie wechseln, sauber machen und wieder reinstecken.
Wie oft wechseln Sie es?
Ja, jeden zweiten Tag.
Jeden zweiten Tag?
Ja.
Mhm. Gut, prima.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Wir möchten heute gerne nochmal zeigen, wie gut Sie fingerfrei sprechen können. Wie geht's Ihnen denn?
Mir geht's gut an für sich.
Wir haben jetzt bei Ihnen 20 Jahre nach der Laryngektomie und 20 Jahre nach der Laryngoplastik. Wie kommen Sie denn zurecht zu Hause?
Alles gut.
Wie geht es mit dem Essen und Trinken?
Keine Probleme.
Wie geht es?
Noch nicht so heiß.
Wie bitte?
Noch nicht so heiß.
Nicht zu heiß. Ja. Wie klappt das denn mit dem Atmen bei Belastung? Kriegen Sie immer gut Luft?
Normal, ja. Ja.
Können Sie mal langsam von 1 bis 10 zählen?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Können Sie jetzt mal ganz leise sprechen?
Leise sprechen. Flüstern.
Genau, und mal laut und kräftig rufen.
Hallo.
Jawohl. Und können Sie mal einen Ton lange halten, mal A sagen, solange es geht. Jawohl. Gut, also dann bedanken wir uns nochmal recht herzlich für das Video.
Gern geschehen. Ist dann in den Griff gekriegt und dann nachdem war da alles in Ordnung. Ich konnte schon nach 14 Tagen, habe ich schon gesprochen.
Genau, da haben Sie aber noch die Hand benutzen müssen.
Ja, ja, ganz klar.
Und Sie haben jetzt das neue fingerfrei sprechen.
Richtig.
Und damit kommen Sie gut zurecht.
Einwandfrei.
Ja. Zählen Sie doch mal bis 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay, also das geht mit einmal Luft holen, aber ganz gut. Und
Also bis jetzt auf die leichte Halsschnapse, weiß ich, wo die herkommen.
Naja gut, das ist jetzt die Jahreszeit, wo man sich mal einen Infekt holt.
Ja, oder ich denke auch, was ich ganz arg merke, ist, wenn es eine sehr trockene Luft ist.
Also
Wir waren jetzt übers Wochenende mit dem Auto unterwegs und waren dann, das war so eine Klimaanlage, ne? Im Hotel, und also das merke ich dann ganz extrem.
Das ist unangenehm beim Sprechen, oder?
Es ist beim Sprechen sehr trocken, mein Hals ist sehr trocken.
Laryngoplasty can also be performed as a secondary procedure. This was a 6-year-old boy from Russia. He suffered from an embryonal rhabdomyosarcoma of the larynx. Following chemotherapy and irradiation, we had to perform a salvage laryngectomy. After 8 years without recurrence, we carried out a secondary laryngoplasty. This microvascular laryngoplasty is now carried out since more than 30 years in hundreds of patients. If anybody has any questions, you can send me an email. This is my favorite motto with my team. Success depends on a good team. So thank you for your attention.